another one. This is called a Cook's catheter, and you might see this in your clinic as well. This catheter, and I had the adapters for them, but apparently someone threw them away or they're misplaced. But yeah.
Quick question, are they always those colors or no, do they come in different
They come in different colors. This is very common though, this blue one.
Okay.
So then the advantage or the difference between the Cook's catheter and like a bougie is you can actually run oxygen through this. You can also bag your patient through it. It has two adapters. One adapter would fit oxygen tubing. So if this was in, so let's say somebody was a difficult airway and you couldn't get them intubated, but you could get this in, and maybe you're also having trouble hand ventilating, like a very obese patient, they're going to be very hard to bag. So with this, you could deliver oxygen to keep the saturations up, but you could also ventilate through it. It looks like you couldn't, but you could. There's a little adapter that has the 15 mil adapter, like the end of the endotracheal tube, and you literally can put your ambu bag on it. I didn't look for a video for this one, but I'll look later and see if we find one. So same principle, either you're intubating and you put this in, or you're gonna use it as an airway exchange catheter and do the same thing. So it's just the difference is I can put oxygen in line with a Cook's catheter and I can ventilate through a Cook's catheter, okay? Students have been asked to get those before at clinic. Yes?
So if I know it's like a guide and whatnot, but aren't you still worried about, you know, trauma to the airway if they're laryngospasming and you're trying to still put that?
Yeah, but if you don't do something, the patient's gonna die.
Okay.
So-
You should expect that you're gonna tear something.
No, not necessarily.
Possibly.
It's inflammation and spasming. So these are, if you can get anything through a laryngospasm, it would be one of these. As you saw yesterday, there was a hole, it's just incredibly small. So at least that could help you do something to your patient until you can get the spasm, giving them paralytics and getting, part of it is, I don't know if anyone in this room's ever had a laryngospasm. I have, because I have a reactive upper airway, and it's not fun, and it's incredibly scary. So just the stress from all that with your patient, getting them calmed down helps as well. And you have to know that, like mine eventually clears, but for that patient has probably never had it before. They have no idea what's going on and they're scared. So you have to do what you can to get them ventilated. So plus we showed you yesterday too, but positive pressure can help break it as well. So that's what you're really waiting for the spasm to break so you can get an airway back in, or maybe they can just start breathing again. Okay? So something else that can go wrong is the pilot balloon. Can get cut, literally cut. It happens every once in a while. A nurse is doing something or someone's doing something and you're, you know, maybe changing a dressing or whatever, and the pilot balloon goes bad or it gets cut because it's wrapped up in stuff. So if that happens, there is a solution. So if your patient was going to be extubated soon, the solution would be to do a temporary fix, like I'm going to show you, and just leave it, or do a temporary fix and get a bougie and re-intubate, so depending on the situation. So they actually make pilot balloon repair kits. I don't know how accessible those are in the hospital, so there's a pilot balloon repair kit basically is a tubing like this with a pilot balloon on the end of it, and on the very end of it is what looks like a needle. It's a little small, very thin metal piece that you would put into here to basically put it back together, like a little extension. And that's a pilot balloon repair kit. But if you don't have those, a very small needle gauge syringe works very well, like a 24 gauge. I just use an ABG syringe here to show you. The other thing you need is a pair of hemostats. Hemostats are these grippy things. It's a clamp. So hemostats are a clamp, but these are going to clamp together and it'll hold it. So what you can do, and students have had to do this too, so you could be the one, because this syringe doesn't have a lot of air in it either, that's the other thing. So basically though, you take your 24 gauge needle and you're going to insert it into the tubing from the pilot balloon. like this, so simple,
Just don't stab yourself.
Yeah, without stabbing yourself.
without stabbing yourself, you won't. And then you're gonna put air in the cuff. And this one I'd have to do a couple times, but whatever. So let's say you have a regular size syringe, you put all your air in the cuff, and then you're gonna clamp it off like that. And that'll hold the air into there until either you extubate the patient or you can put a new tube in. And it works. It works. So, we've done it before. It works very well.
So if you use the ABG syringe, does that have heparin in it?
Yeah, you're not gonna use an ABG syringe in real life.
Okay, I was like.
I'm just using a syringe to show you. Just get a needle with a 24 gauge, a syringe with a 24 gauge needle on it, because that's what's small enough to go into the tubing on the pilot balloon. Insert your air, your 8 cc's or whatever for now, clamp it off with your hemostats, and then either wait to extubate if the patient's being extubated soon or re-intubate. But that'll hold. If you're not sure if your cuff is bad, you can do this as well and put more air in and clamp it, and then if the cuff, if you lose the air, then you know for sure it's the cuff and not the pilot balloon, because maybe you can't quite figure out. So if you put air in and then clamp it and then the cuff goes bad down again, then you know for sure it's the cuff. That's bad and needs replaced. Does all that make sense? Okay. What else could we have a problem with our airway? Biting, yep, biting the tube. So that's what we have a bite block for. The Hollister, as I showed you yesterday, has a bite block built in. They also have separate bite blocks. And then what did we talk about last week that you could also use? An OPA. Remember, not all the way in. We would just be putting it right here, tape it in place to hold the teeth from. Because if your patient's biting, nothing's happened with that vent or you, because they're just going to be chomping down on it. Anybody think of anything else?
Hands,
Huh?
so you're trying to grab it?
Yeah, well, yeah, that would be a problem if they pulled it out. Restraining. Not everybody wants to pull their ET tube out. You guys are going to see lots of people not restrained, not sedated with endotracheal tubes in. Don't be surprised. This is how it is. But if your patient is really trying to yank it out, restrain them. You might have to sedate them, because patients, you'll see them what I call shimmy down the bed, and they're going to go like this. And even though their hand's all the way down there, they're going to shimmy down the bed to try to reach that tube. That's a patient who wants to take it out at all costs. And you'll be like, wait! Or that's kind of the one when they're yanking it out and you're going, no! And it's too late because it's already out. But yeah, don't just think because they're restrained, they can't get the tube out. They can. They shimmy down the bed and scoot themselves all the way down until they can reach it, and they'll pull it out. A lot of patients, just a little fun fact, about 75% of patients who pull their tube out, I mean, this is just what they've found over the years, that are well enough to pull their tube out can have it out. So we don't automatically re-intubate the patient. We assess them and see what needs to happen at that point. Okay, you could get a kink in the tube, so that's going to cause a high pressure alarm because it's got a blockage in it, and it's sometimes just because of the patient's anatomy, it kinks in the back there. It's kind of hard to tell, but you kind of can usually tell if you look. Also, secretions and mucus plug. Yes.
That's exactly what happened when the code blue, when they intubated him. And then we put him on a ventilator and we walk away for like 30 minutes because he's stable. And the nurses calls back in and he was having like flash pulmonary edema. It was almost to the vent circuit, like it built up all the way through the tube, almost into the circuit. And then when my preceptor like took out the circuit to like clean it, it shot out.
Yes.
So that's why I know why you say stay at the side of the vent. It literally shot out.
Was it the pink frothy secretions?
It looked just like pink. Like
Yes.
Like a nasty, nasty pink.
Like pink egg whites.
Disgusting.
I told you guys that this is what it would do. Isn't it exactly what I talked about? I said your pink frothy secretions will come shooting out of the endotracheal tube. They've got nowhere to go except out. So you got a perfect example of it. You guys will all see that at some point. So you have to suction, suction, suction. So that's from pulmonary edema, and I mean it is everywhere, and you're working to get rid of it. The other thing though can also be just from secretions, like patients that have lots of very thick secretions. So you can have thick secretions that are in the way, but you also can develop a mucus plug because of that. That's totally blocking off the airway. So you go in and your machine is just alarming like crazy because it's just like hitting. So just pretend this whole tube is blocked. It's just like hitting a roadblock, and it's just gonna, and then if you have all those pink frothy secretions in there, it's gonna be doing the same thing. You can't ventilate a patient. So that patient has to be hand ventilated. Is that what you guys did? Correct?
Because she did the Ballard suction, and then we got most of it out before like any like major respiratory.
Oh,
distress
okay,
happened.
that's good.
Yeah.
But a patient who's really in severe CHF, a lot of times you have to hand ventilate them until you can get them a little settled down and all that, because the difference of bagging here as opposed through the ventilator actually makes a big difference. And I'll show you about the PEEP valve in a minute too. But the patient is, so let's say your ventilator is just alarming. So this would be a high pressure alarm. So basically it's just hitting this alarm and stopping. And your patient is deteriorating and you can't figure out what's wrong. So what's the first thing you could do? They're on the vent right now. Say they're attached to the vent. The vent's just alarming like crazy. Your patient's desaturating.
You could take it off and bag that.
Take them off and bag them. Absolutely. That's the first thing that you're gonna do. Your vent is alarming in any way, shape, or form, and you can't instantly fix it, like seeing that it's something unplugged or unhooked or whatever, you're gonna bag them. So now I go to bag them, and I can't bag either, because it's so much resistance. What does that tell me? Possibly, but the problem is with the patient. Because if it's not, what should happen? You should be able to hand ventilate them properly, right? So if I take them off, I have a problem, I take them off, and I'm bagging the patient, and everything's good, my SATs come back up, my patient's doing well, the problem's with the vent. Does that make sense? Because I took over and everything's fine. But now I take over and everything's not fine. My patient's still in distress. It's a problem here with your patient. So let's say you're trying to ventilate and you can't. It's just like a rock. You can't get any air in. So now I'm gonna suspect a plug or a blockage of my tube in some way. So now I'm gonna take them off and I'm going to pass a suction catheter. Do you guys have a suction catheter in here?
Mhm.
Yeah. Either the Ballard or just get a regular one. You could throw the Ballard on and see if it will go. So I'm gonna pass a suction catheter. I try to pass a suction catheter and I'm stuck. What do I do now? Okay, this is where you're gonna get two different ways. This is one of those times when we have the test way and the real world. So your patient's distressed, I can't bag them, I can't pass a suction catheter. If you're taking your test with the NBRC, you're going to extubate the patient and re-intubate them. You would not be able to use a bougie. You just gotta take the tube out and get an airway going again for your patient, because when that tube is plugged, they're not breathing, they're not doing anything, they're gonna code on you. Never on the test do you instill saline directly down the endotracheal tube if it's not a bronchoscopy procedure. So you're gonna learn to just dump saline down the tube and bag them. But you would never do that on the test. They don't do it. I don't know why. Someday they'll change it, but they don't. So that's never a right answer. Now you'll learn about a lavage that we do during a bronch. I'm not talking about that, that's different. I'm talking about you as an RT dumping saline down the endotracheal tube and bagging them. So it'll say instill saline down the endotracheal tube, never right on the test. And if we're in here and we're testing, it will say, if you're on the MBRC and you come across this, what would you do? And you would extubate. Now, in the real world, we put saline down the tube. So pink saline bullets, or you can get a large syringe of saline, you're gonna squirt it down there and you're gonna bag the heck out of the patient. This is the time when you can go bag like crazy. So what will happen is, in a perfect world, and it actually is very effective, that saline will help break up that mucus plug by hydrating it. You'll hear a sound change, kind of hard to explain. But so when the plug is there, you can't do anything. Once the saline goes down, you'll start to be able to bag a little bit. You'll hear the secretions loosen up. You might have to put more saline down. Don't worry about 20, 30 cc's, you guys. It's not gonna kill your patient. You're not drowning them. Yes?
This happened when I was in the hospital with my instructor, and she was like dumping saline down him.
And you were probably just like,
I was like, what's going on? I didn't ask her at the time, but and she was like trying to make the patient cough, and I was bagging, and she was like, you need to do the whole bag. And I
Yeah.
was like, that's not what we learned in school, but okay. And then-
that's just for this situation you do.
Yeah.
So
And
literally
you're
you're putting saline and you are going like this.
It was
because you are trying to break it up. So you're using, like, you're actually exerting force onto there.
It was weird. He was coughing so much.
Yeah. Yep. Did you see that too? Because I kind of saw you.
We did bronchial lavage.
Oh, okay. That's the other kind of lavage. That's okay, but that's actually through a bronch. So literally, 20, 30 cc's, you guys. It's not going to hurt your patient. It'll be reabsorbed. Some of it you'll suction out. You're not. Some people are like, they're going to drown. No, they're not. So, and then you're going to bag as hard as you can to start to break it up. If you need to, put more down. As long as, and people are like, how long do you do this for? You got to watch your patient. But it's very effective, and most of the time it will start to clear, and then you can get it enough so that you can start to suction it out even though it's thick. Then you can put more saline down and then start to get it cleared. If your patient is really deteriorating and you're not effectively doing this, then you have to extubate. But this is something that you'll just see in clinic and learn through clinical judgment and your critical thinking in time. Mitch?
So, I know it would be different for every situation, but while you're sticking all the saline down there, they're still not breathing because you know, or is air getting past the
Once you start to do that, and you'll be able to tell if you're getting some air through. If you do a whole round of saline and bagging and you're not getting any air through, you're gonna have to take the tube out because the patient will not be able to breathe. But it's actually very effective and it works well. So that's how we're gonna deal with that clinically. So you will instill saline down, and it's actually a fairly common practice. Okay? Yes?
How do you take the tube out if they can't cough? Like if you can't.
You just take it out. Just rip it out. Take the cuff down and take it out. Because they're gonna die if you don't do something. So it's not like a normal extubation. It's an emergency, get the airway out so we can reestablish a new airway for my patient. Then put a mask, BBM, get your mask, and continue on from there. Okay? So the other thing I wanna show you is use of a PEEP valve. So you guys have these in your boxes. The PEEP valve is gonna go onto the end of your ambu bag where it says it's an exhalation port and it says do not occlude. We're not occluding it with this, so it goes right on there. So this is gonna provide PEEP to your patient like we're doing PEEP through the ventilator. Also the same as CPAP. Remember we talked about last term, EPAP on a BiPAP is the same as CPAP, which is the same as PEEP on a vent. So you're just providing end expiratory pressure to the airways. When we intubate somebody, we don't normally just put a PEEP valve onto the ambu bag, except it's pretty standard if your patient has that severe CHF, because the PEEP is gonna help disperse the fluid and help get some oxygenation. So the way this works is there is a dial, this turns, and when you turn it, you're going to see there's numbers on here, and there's a black line, and so you turn it to whatever number you want. So if you're going to have a CHF patient and you're bagging right after intubation, I would put it on 10, because that's gonna help. Otherwise, this PEEP valve should be on the end of an ambu bag on anybody that has PEEP on their vent beyond like 5. 5 is very standard. So what do we use PEEP for? Leah?
So what determines if they had to use double of those? Because they use 2 PEEP over PEEP.
They use 2?
Yeah.
How did they use 2?
Because there was like one of those, and they put another one on it while we were bagging.
Huh. I don't know how you would put
Like
2 on there.
extra pressure or extra.
It must be another attachment that goes on there.
Okay.
Well, this only does 20. So if your patient is on more than 20, you would need something different.
Okay.
So there must be a different way. I'll have to look that one up. I've not seen that.
I know. I was like, that's interesting.
So this only does 20, and patients could be on 25, even 30, as crazy as it sounds. So what is PEEP gonna help do? Keep their airway open, but what else does it do? Why do we put someone on CPAP? For what?
Prevent collapse.
Okay, but
Increase the FRC and decrease the residual volume.
yeah, I mean those are all true. But what about it?
Diffusion?
Patients' PO2 is 50 on 100%. What is PEEP gonna do? Allow for better oxygenation, because we're gonna help open up. Next week I'll show you on that, because we won't have time today because I want to hear about your clinic stories. We'll get there's pig lungs back there, and I'll actually show you a demonstration on how PEEP will, let's say you have all these little alveoli that are filled with fluid and secretions and all kinds of stuff, and they don't want to open up. So they're collapsed, and what we want to do is what we call recruit. We want to recruit, like we're trying to recruit our team. We need to recruit all those alveoli to get them opened up, because if they're not opening, there's no oxygenation occurring. So that's what PEEP does on a ventilator, is it helps recruit alveoli that have collapsed for whatever reason, atelectasis, secretions, fluid, whatever that might be. So you'll see patients that have ARDS, very, 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 very severe oxygenation problems, the worst you're gonna see. And so we put them on large amounts of PEEP, along with a high FiO2, because we have to. And the PEEP is there to help recruit the alveoli, which you'll see when we put them on the pig lung. So some of these patients are on very, very high levels of PEEP. And it can take 8 to 10 hours, your entire day, to recruit the lung in your patient and finally get them saturating better. So you come in, the patient's sats are in the 80s, you've been working with them all day, FiO2 changes, you've been increasing your PEEP, and you finally get their sats maybe up to 91, which would be a major accomplishment for that patient. And they're stable and they're doing good. So let's just say they're on the vent. We've got our PEEP on, everything's good. And the patient becomes disconnected. Guess what just happened? All your work, all day long, was just lost. Because de-recruitment is instant, as soon as you open it back up to the atmosphere. Patients that have endotracheal tubes in have no residual PEEP in them, because we're bypassing the airway, so you don't have the normal glottic closures and that you have. So even our 5 of PEEP is meant to replace that. So as soon as you unhook the patient, they've lost all that. So it can happen with a nurse, it can happen with a lot of different reasons, but what if your vent is bad, or you need to do something to take the patient off the vent? There is a solution. And you'll see this in your clinic setting too. And what we're going to do is we're going to do a procedure where we clamp our endotracheal tube so as not to lose PEEP. So for patients that are on high levels of PEEP, 15 or more maybe, you'll know the patient. They're on incredibly high FiO2s, they've got a terrible x-ray, they're on high levels of PEEP, and something happens, or for whatever reason, we need to unhook them from the vent circuit. So what you're going to do is use your trusty hemostats again. This is why I said you need these hemostats with you. And you're going to, I just used a paper towel, but you'll use like a little piece of gauze, because you don't want your clamp to go through your tube. But, so if this were a little piece of gauze, I'm gonna let the ventilator deliver a breath to my patient, and then I'm going to clamp off my tube. And I'm going to disconnect my circuit with my tube clamped. My PEEP valve is on my ambu bag. I'm gonna connect my ambu bag. I'm going to unclamp, and then I can bag. And because I did that, I lost no PEEP. So no de-recruitment, no deflation of the lungs. Yes?
You worry about the tube kinking after that?
Nope.
No?
It comes right back. It's a quick procedure, so I'm gonna show you one more time. So remember, you're gonna have your PEEP valve on your ambu bag, and anybody who's on PEEP, the PEEP valve should be on the ambu bag ready at the bedside. So if you need to be in an emergency situation and bag the patient, it's ready to go. Yes?
You would want your PEEP valve to match the PEEP that you
Yes.
put on the.
So if I'm on 20 on the vent, this should be on 20, which means you would dial it down to the bottom of this is right at the black line. And if it's whatever, it's 20, maybe 21, it's fine. Okay, so patient needs to come off the vent, we give them a breath, we clamp our circuit, we take the circuit off, put the bag on, unclamp it. Don't do that, my thumb's stuck now. Unclamp it, perfect. And now, so no de-recruitment, everything's good, yes?
So you're only using the PEEP valve when they're like on a vent with PEEP, or if they have CHF, right?
Yeah, PEEP is used all the time.
Like even
So-
if you're bagging like all the time, you always have the PEEP on, the PEEP valve?
Yep. Because this is gonna replicate the PEEP they're on the vent. So if you need to hand ventilate them for some reason, you need to have the same amount of PEEP.
But like, before you intubate,
Only probably on a CHF patient would you use the PEEP valve during intubation. That's why I'm saying, now this is a patient on a vent on high levels of PEEP and we need to unhook them for some reason.
okay.
That's when we're talking about here. So I'm bagging my patient now, no de-recruitment, my lung stays inflated, everything's good. Now I need to transfer back to the vent. We're just gonna do the same thing in reverse. So, and this is usually something that it's best with 2 people if you can. So give your breath, clamp it off. Clamp it, take off your ambu bag, put your vent circuit back on, unclamp it, and you don't lose any of your PEEP, and no de-recruitment. So that's how that should be done. A lot of places do it, a lot of RTs do it. You will occasionally see an RT who doesn't do it. Ask them why they're not. Watch the patient's sats go down after they unhook them. It will. So that's what you're gonna do for that on your high levels of PEEP. Let's see, what else do you want? I think that's everything I wanted to show you for that. Are there any questions?
Right here. I was wondering, what, you said the PEEP level on the dial, on the PEEP valve is also equivalent to the PEEP level of the payment.
Yes,
When would it be different?
it would not be.
Okay.
It should always be the same. Kelsey?
The little trick that you showed us with the hemostat and the gauze, so that you don't lose the recruitment, is that just if there's an issue with the vent and you would need to go to manual bagging, or?
Well, what if there was the problem is just that the situation is there's a problem. The problem could be the vent or the patient.
Okay.
But either way, you don't wanna lose all that PEEP.
Okay,
So that's just a very quick procedure you can do to get your ambu bag on and not lose all your PEEP.
because then let's say you did that, like it was clamped with the gauze, and then you go to bag and it's hard, like a rock, you have to do the saline and you still wouldn't lose.
No, you would in that situation, but in that
Okay.
situation, you have no choice.
Okay, got it.
Because there's a mucus plug now. So
Okay.
that's gonna be a different situation. This isn't a perfect world where we don't wanna lose any PEEP. Sometimes you have to unhook, there's nothing you can do because that's the only thing that's gonna work.
Is the more common type of a problem with the ventilator or a problem with the patient?
Probably the most common thing we see are small leaks and then pressure alarms because patients are coughing and need suction. So, depending on where you work, you might not see this because this is very sick patients and they don't typically stay at your rural hospitals, but the other problem is sometimes they're too unstable to be transferred. So, but these are the ones I'm talking about where you have to do this procedure is your sickest, they're your ARDS patients, which are gonna be some of your sickest patients you're gonna take care of and hardest to manage. What else? Okay, before we take a break and I show you these videos about trachs, I wanna talk about ventilator-associated pneumonia, also known as VAP.